In this video, we'll talk about alcoholic liver disease. So it is caused because of chronic and the excessive consumption of alcohol. So this liver disease will be occurring in the 4 stages. The first stage is fatty liver, then it leads to alcoholic hepatitis, cirrhosis, and the hepatocellular carcinoma is the last stage. So these 4 stages are the stages of alcoholic liver disease. So coming to the risk factors for this alcoholic liver disease, the first is quantity. If the male is drinking 40 to 80 grams per day, it can cause fatty liver. If he is taking 160 grams per day for 10 to 20 years, it can cause cirrhosis, right? And coming to the gender, females are usually more susceptible for development of this alcoholic liver disease because of the hormonal factors. So even if they take this low amounts of alcohol like 20 grams per day, it will still lead to alcoholic liver disease. So females, the susceptibility is more. Coming to the hepatitis C infection, so this hepatitis C, if it is associated with alcoholic liver disease, it will cause a poor prognosis. And genetics, some people are more genetically predisposed to developing hepatic cirrhosis, right? So this PNPLA3 gene association will be usually associated with alcoholic cirrhosis. So that is the role of genetics in the development of alcoholic liver disease, right? And the next thing is fatty liver, whether it can be because of this alcoholic fatty liver or even if it is non-alcoholic fatty liver, or it can be because of obesity. All this condition will still carry a risk for development of alcoholic liver disease. So quantity, gender, hepatitis C, genetics, and the fatty liver. All these are the risk factors for alcoholic liver disease. Now if we look at the pathogenesis, I remember it using this mnemonic free holy. It has 2 R's and 2 E's in it, and holy as 2 I's, right? So the first one is fibrogenesis. So what happens in the alcohol intake? There will be activation of Ito cells. Ito cells or the stellate cells will get activated to form myoepithelial cells. So this myoepithelial cells will be causing this fibrogenesis. And the second is redox reaction. So there will be more NADH compared to NAD. And the third is retention of water and protein, which will cause hepatomegaly. And 6, direct toxic effects of ethanol, which will be damaging microtubules and the mitochondria of liver. And the next is ethanol metabolites like acetaldehyde will cause damage, which will produce adducts. So this acetaldehyde will form 2 adducts. One is protein adduct and second is MAA adduct. Protein will cause damage to cytoskeletal system, whereas this MAA adduct will be forming autoantibodies and damage the liver. So that is the effect of ethanol metabolites like acetaldehyde on the liver. And the next thing is hypoxia. So this hypoxia will be causing necrosis, centrilobular hepatocellular necrosis. And the next one is oxidative stress. So this reactive oxygen species will be causing damage to the liver. Liver fat deposition, again leading to hepatomegaly. And then inflammatory reaction like alcohol intake can trigger this inflammatory processes like release of TNS alpha, interleukin 1, interleukin 6 and cytokines. All this will be damaging liver. And immunological reaction like cell mediated immunity will be impaired in the people who take alcohol. So these are all the different factors which will cause damage to the liver by alcohol intake. Now in this slide we'll talk about the different stages of alcoholic liver disease, and we are going to talk about the symptoms presenting in the each stage and the lab findings in the each stage, right? Now coming to the alcoholic fatty liver, it is the first stage of alcoholic liver disease. So there will be discomfort in the right upper quadrant associated with nausea and the jaundice, and it's a reversible condition. So if there is any cessation of alcohol in this stage, this fatty liver can be converted back into normal healthy liver, right? Now if you look at the lab values, ALT and AST will be raised and AST is to ALT will be greater than 1. See here you have to remember one point. In normally this ALT will be greater than AST in any liver pathology, but in case of pathology involving this alcohol, AST will be always greater than ALT, right? So here it is greater than 1, it is 1 to 2, and here it is greater than 2. In the USG you can see this echogenicity, and fat accumulates in the periventricular and entire hepatic lobule on the biopsy. So if you take out the biopsy from this fatty liver, you can see this fat accumulating in the entire liver lobule, hepatic lobule, in the perivenular and the entire hepatic lobule. So this is about alcoholic fatty liver. Now coming to the next stage, which is alcoholic hepatitis. So itis, inflammation, infection, so there will be fever and rapid onset of jaundice, abdominal pain, discomfort, liver hepatosplenomegaly, and also there are some things involved, you have to keep this in mind: portal hypertension, ascites, bleeding from esophageal varices, spider navy. Everything is involved except cirrhosis. So portal hypertension, ascites, esophageal varices, everything is involved in this alcoholic hepatitis stage except cirrhosis. Cirrhosis will be seen in the third stage. So this is about alcoholic hepatitis symptoms. Coming to the lab findings, you can see again AST and ALT which will be greater than 1 to 2. So again you can see this AST to ALT ratio from 1 to 2, and there will be rising of serum aminotransferases from 2 to 7 times, Bilirubin will be increased because of the jaundice. ALP will be rising and decrease in albumin. Prothrombin time will be increasing, causing leukocytosis. Now coming to the biopsy, you can see this ballooning, Mallory bodies and leukocytic infiltration. So this is important to keep in mind in the alcoholic hepatitis. You can see this ballooning, degeneration of hepatitis, Mallory bodies and leukocytic infiltration. Because of this leukocytosis, leukocytic infiltration is also seen, right? There is inflammation, there is infection, so there will be rising of leukocytes which will be causing leukocytic inflammation. There will be fever, rapid onset jaundice, and all these things can be seen. So this is about alcoholic hepatitis. Now moving to the third stage, which is alcoholic cirrhosis. Again you can see this ascites, portal hypertension, edema, hepatic encephalopathy, upper GI bleeding, esophageal varices bleeding, spider angioma, icterus due to jaundice. All this can be seen along with cirrhosis, right? So here in the cirrhosis there will be firm nodular edge of the liver. On the end stage it will be shrunken liver. So what do you mean by this? Suppose this is a liver, and in the cirrhosis there will be degeneration of the liver. So this is the degenerated part of the liver, and the rest thing is healthy part of the liver. This is the degenerated part, right? This healthy part try to regenerate more liver tissue, right? So it forms and try to regenerate and forms these nodules. Some might be small, which will be causing micronodules, and some might be large, which will be macronodules. So this entire liver will be firm and nodular in the initial stages of cirrhosis, right? Later what happens? It will be shrunken, it will be small, it will be fibrotic. Why? What is the reason? Because of obstruction to the blood flow. So the blood capillaries or the blood vessels which will be supplying to the growth of this liver tissue will be getting obstructed. So that is why it will be causing this fibrotic liver in case of end stages of cirrhosis. So that is the meaning of this. Hepatosplenomegaly can be seen along with the firm nodular edge of the liver initially, but on the end stages there will be shrunken liver. So even in the biopsy you can see this shrunken fibrotic liver with this function. So this is about cirrhosis. So what are the things you can see in the cirrhosis? So just mention what are the things you have mentioned in the hepatitis, like ascites, portal hypertension, edema, variceal bleedings can be seen, encephalitis can be seen, spider angiomas can be seen along with cirrhosis. So just write about this cirrhosis part, right? So again you can see this muscle wasting, clumping, hepatosplenomegaly, icterus and spider angiomas. Now coming to the lab findings. So anemia will be there because it's a chronic condition, and there will be variceal bleeding and liver dysfunction and all, so there will be anemia. And thrombocytopenia can be there, increase the serum bilirubin because of jaundice. Prothrombin time is also rising, and ASTs to ALT will be greater than 2. So here in the cirrhosis stage it will be greater than 2. In the hepatitis it will be from 1 to 2. In this fatty liver it will be greater than 1, right? Normally the serum sodium will be normal, but if this stage, if it is involving any ascites, it can lead to hyponatremia also, right? So this is about the different stages and the symptoms and the lab findings. Coming to the poor prognostic factors, for example, poor prognosis is seen if there is any organ involvement other than liver. So if it is involving kidney, renal failure can cause poor prognosis. Hepatorenal syndrome can cause poor prognosis. Again, any failure in liver and kidney can cause this albumin which is less than 2.5 gram per dl. It is also a poor prognostic factor. If it is involving brain, it can cause hepatic encephalopathy, which is again a poor prognostic factor. Anemia, ascites, and if there is any jaundice, bilirubin greater than 8 mg per dl, coagulopathy, and discriminant score greater than 32, variceal hemorrhage. All this will be poor prognostic factors. You can remember by A, B, C, D, E, F. A stands for anemia, ascites, albumin less than 2.5. Right? B stands for bilirubin, C stands for coagulopathy, prothrombin time greater than 5 seconds, and D stands for Madry discriminant score which is greater than 32, and E stands for encephalopathy, F stands for failure of liver and kidneys, and H for hepatorenal syndrome and variceal hemorrhages. Coming to the treatment. So first we'll advise the patient to stop drinking alcohol, and we'll give them good nutrition which is rich in vitamin B6 and the C, and then we'll treat the associated conditions. If any ascites is present or the encephalopathy is present or jaundice is present, first we'll treat that conditions, and then we'll see if he is eligible to take this prednisolone 40 mg. So how will we check that? First, he should be in the complete abstinence of this alcohol, and he should be taking this nutritious food, and we'll check two scores. One is MELD score, which should be greater than 21, and discriminant score should be greater than 32, and there should be no comorbidities and no complications. To this person we can give prednisolone 40 mg, right? And other treatments are also available where you can give them N-acetylcysteine, pentoxifylline, antimicrobial therapy to treat the secondary infections, and avoid this hepatotoxic drugs. Granulocyte stimulating factor can also be given, and the last option is liver transplant. So this is about alcoholic fatty liver. Bye.